Hello everyone, it's Mo here, and today we're going to be talking about... Hello everyone, it's Mo here from Pareto, and today we're going to be talking about asthma, the silent killer. Now I know what you're thinking, asthma is not silent. The shortness of breath, the wheeze makes it far from being silent. However, there are certain physiological parameters that we really need to look out for in dealing with patients with asthma, where if we don't pay attention to them, they can result in a significant and fatal deterioration in the patient's health. So let's get to it. Now, with regards to asthma, the moderate, severe and life-threatening categories should be very clear to you. You've probably gone through them a number of different times in lectures and even during revision and even on placement. So if someone has life-threatening asthma, you notice that their SATs are dropping, they have a silent chest, and also they're having increasingly poor respiratory effort. It's getting shallower and shallower and shallower. Their breathing, that is. But let's transition to their arterial blood gases, because their arterial blood gases also reflect the transition in disease state with regards to their asthma. So for instance, in someone with mild asthma, you'll find that their pH is high, primarily due to the fact that they're breathing incredibly quickly, blowing off CO2 in order to maintain a constant level of PO2. That makes sense. However, as the disease process worsens, so they transition from being mild to moderate to even severe, you start to notice some changes. You firstly start to see that their PO2 drops, which makes sense. They've obviously got an asthma exacerbation, and it's becoming increasingly more difficult for them to maintain their oxygen levels. However, you then find that their CO2 levels go from being quite low to being normal. This is where asthma becomes the silent killer. Because if you imagine, if someone has an asthma exacerbation and they're breathing incredibly quickly, their respiratory rate should translate in them blowing off lots of CO2. But because they've got airway bronchospasm, their body is less able to blow off their CO2. And that starts to subtly translate even in the bicarb level and more specifically the pH level, which goes from alkalotic to normalizing. Now you'd look at that on the surface and think, not a bad gas, pretty normal. Yeah, they've got some asthma and that's about it. But then let's fast forward maybe a couple of hours and you get a severe picture. The pH drops. Why? Because the PCO2 starts to increase. Their blood starts to become more acidotic. Their PO2, of course, drops further and their bicarb drops as well. So they start to develop respiratory acidosis. So we need to treat them, and we need to treat them quickly. And how does that work? We start by giving them back-to-back nebulizers, salbutamol 5 milligrams and ipratropium 500 micrograms, and we give them back-to-back constantly in order to try and reduce the level of bronchospasm that they're undergoing. We give them some steroids in order to reduce the level of inflammation that their airways are under. So that includes hydrocortisone or prednisolone, whichever or, really, they're both equally bioequivalent. And then if that doesn't work, then we consider magnesium sulfate, which is quite a novel treatment that we don't really have a clear picture in terms of how it works, but it does wonders for severe life-threatening asthma exacerbations. Now, if that doesn't work and you see their pH worsening, you see their PO2 reducing and their PCO2 increasing further, then it's time to call ICU for invasive ventilation, such as intubation. And that's when it gets really bad. So that's why I call it the silent killer. And that's why we need to really be careful about what asthma can lead to. And that's it. So thank you very much for listening, guys. And until next time, see you later.